Hello and good afternoon, friends. Welcome to the CEC EduSet live lecture. Dear friends, as you know that in our previous session, we talked about vector-borne diseases. We specifically talked about dengue and chikungunya. Today also we would be going to talk on other kind of vector-borne diseases, and those diseases are leishmaniasis and filariasis. And for this, we have again with us in our studios Dr. Amit Bhattacharya. As you all know that Dr. Amit Bhattacharya is Assistant Professor in Department of Zoology, Ramjas College, University of Delhi. So dear friends, let's take advantages from his experiences and try to understand more about these two vector-borne diseases. So first of all, I would like to welcome our guest, Dr. Amit Bhattacharya. Dr. Bhattacharya, welcome to the EduSet lecture.
Thank you, ma'am. So, dear friends, today I am going to speak about the two other important vector-borne diseases. In the last of my lectures, I spoke about the dengue and the chikungunya vector-borne diseases. So, before starting, let's just brief up what exactly vector-borne diseases means. So, vectors are nothing but the living organisms which transmit the disease from one person to the other person. So, the most common example of vectors are the mosquitoes, sandflies, bugs, ticks, like these things. So, all of these acts as the vectors in transmitting the diseases from one person, infected person, to the other healthy person, and subsequently the disease rise up around the area. Now, there are few important vector-borne diseases. The last two vector-borne diseases which we discussed were the dengue and chikungunya. In this part of the lecture, we will discuss about the leishmaniasis and the Japanese encephalitis, malaria and filariasis are the other part of the vector-borne diseases. So, today we will concentrate upon the leishmaniasis and filariasis. So, we come into first part of this lecture, which is the leishmaniasis disease. So, this leishmaniasis disease is a parasitic disease which is found in the parts of tropics and subtropics and the southern Europe. It has been classified into the neglected tropical diseases and is spread out by the bite of these sandflies, which is shown in the pictures. And these sandflies, what they do is when they bite the person, they inject these promastigote stages, and these promastigote stages are called as the flagellated promastigote stages. So, we will discuss upon the structural part of these stages, how these stages get transferred through the body and comes into our body circulation. The most common form of these leishmaniasis disease are cutaneous leishmaniasis, which causes skin scores, and the visceral leishmaniasis, which affects the several internal organs such as the spleen, liver and bone marrow. So, what's the biology behind or the causal agent which causes this leishmaniasis? As I told you, it is caused by an intracellular protozoa of the genus Leishmania, and there are about 21 to 30 species of these Leishmania are present, of which the most common one is the Leishmania donovi, Leishmania infatum. So, there are a number of species which causes the human infection. Now, if we see the slide over here, the visceral leishmaniasis, there are about 3 lakh cases which are reported, and over 20,000 deaths have occur annually. While cutaneous leishmaniasis, which is more prevalent and common, causes about 1 million cases of cutaneous leishmaniasis has been reported in the last 5 years. So, if we take the overall picture of the leishmaniasis disease epidemiology, we can see that about 310 million people are at a risk of infection, of which 6 countries contribute to 90% of these cases worldwide. Now, what are these 6 countries? The 6 countries includes Bangladesh, Brazil, Ethiopia, India, Southern Sudan and Sudan. So, this disease, if we see that these disease mainly affects the poor people because it is associated with the malnutrition, population displacement, poor housing, weak immune system and lack of resources. So, around 98 countries throughout the world, this disease is prevalent and is been transmitted. So, 90% of these cases are reported from the 6 countries which we discussed are Bangladesh, Brazil, Ethiopia, India, South Sudan and Sudan. Now, what exactly happens in this leishmaniasis disease? So, leishmaniasis, as I spoke, that there are about 20 to 30 different species which causes the disease, and they are transmitted to the humans by the bite of infected female sandflies. So the three main forms of this disease are cutaneous leishmaniasis, visceral leishmaniasis, and mucocutaneous leishmaniasis. So we'll take up each of them one by one. Let's take up the first part, which is the cutaneous leishmaniasis. This is the most commonly form of the disease which is formed around us. It usually produces ulcers on the exposed part of the body, such as the face, arms, and legs, and sometimes the lesions or these ulcers increases to a number of 200 also. So this causes a major disability into the patients, and when these ulcers heal, they causes the permanent scar on the face or on the arms or on the legs of the patient who suffer from this particular disease. So many a times this person who suffers from this disease are excluded out from the society because of the scars which are very prominent on their faces, arms, and the legs. The next form of the leishmaniasis is the mucocutaneous leishmaniasis, which is caused due to destruction of the mucous membrane of the nose, mouth, and throat cavities or the surrounding tissues. So over here, if you see the picture, this is the boy who is suffering from mucocutaneous leishmaniasis, and the nose mucous membrane has got destructed due to this disease parasite. So the disease parasite has destroyed the mucous membrane of the nose, causing the disability form in this one. So these patients who generally suffer from these kind of leishmaniasis are often rejected by the community because of their disability. Now we come into the third form of the leishmaniasis, which is the visceral leishmaniasis, which is also known as Kala Azar. Now this leishmaniasis disease is generally characterized by irregular bouts of fever, substantial weight loss, there is swelling of spleen and liver, and it may be leading to serious anemic conditions also. Now, if this disease is not treated, the fatality rate in the most of the developing countries where there is poor conditions of living goes as high to 100% within the 2 years of the onset of this disease in the patient. Now, what are the symptoms or the clinical manifestations which are found in this kind of leishmaniasis? So, in the visceral leishmaniasis, the patient shows the symptoms of fever, there is a weight loss. Over there, the patient shows hepatosplenomegaly, which means that the spleen and the liver cells get increased up or get swelled. Then the patient suffers from anemia, leukopenia. There is a high protein level which increases, low albumin level occurs within the patient. So there are lots of irregularities in the body functions which occur in the patients, and subsequently, if not treated, the patient may die off because of leishmaniasis, visceral leishmaniasis. Now, the visceral leishmaniasis is many a times referred as the Kala Azar, which means in Hindi black fever. Okay, so the Kala means black, Azar means fever. So in the Hindi, it means black fever. It is often reserved for the severe form of visceral leishmaniasis, although many a times Kala Azar and visceral leishmaniasis are used interchangeably. Now, the visceral leishmaniasis has got a post-Kala Azar form also, or the complication, which is called as post-Kala Azar dermal leishmaniasis. Now, in this post-Kala Azar dermal leishmaniasis, the patient who suffers from visceral leishmaniasis develops this kind of post symptoms in which the patient suffers from hypopigmentation. There is maculopapular or nodular rashes which develops throughout his body. So if you can see the picture over here, the patient who is suffering from visceral leishmaniasis, and as the things have got deteriorated or severed, the patient goes into the post-Kala Azar dermal leishmaniasis, where the nodular rashes can be seen throughout his face structure. So the patient's body structures get disrupted, and the patients generally don't recover from these things. Okay, so the PKDL heals spontaneously in majority of the cases in Africa, but rarely in the patients in India. So this is the statistics which is given by the WHO, which is the World Health Organization, which says that these post-Kala Azar dermal leishmaniasis many times remains untreated, and the patient may develop all kind of these rashes onto their face and the body things. So the visceral leishmaniasis is the most lethal of all these leishmaniasis, while the cutaneous leishmaniasis is the most prevalent and commonly found leishmaniasis. So if we see the picture over here, the patient is suffering from this cutaneous leishmaniasis, so we can see the ulcers or the sores within her body, and while the next picture is the patient who is suffering from the visceral leishmaniasis. So we can see the visceral part of the body had got swelled because of the swelling in the liver and spleen. So the liver and spleen have got swelled, so there is a marked splenomegaly or the swelling of spleen which has occurred in this patient. Now, what is the endemicity of these cutaneous and the visceral leishmaniasis within the world? So if we see the statistics worldwide, in the year 2012, cutaneous leishmaniasis was spread around the world. So we can see most of the parts of India, Africa, Latin America, and some of the parts of the America got affected by this cutaneous leishmaniasis. While in the case of the visceral leishmaniasis, some of the parts are very severely affected by this visceral leishmaniasis. So we can see that this leishmaniasis is spread out throughout the world, and what we discussed in the previous slide, that about 310 million people are at a risk of developing the leishmaniasis during their lifespan. So we can just imagine how big and global this disease is throughout the world. Now, what exactly is the situation in India? So if we see the Indian situation in the year 2010, about 15,538 cases were reported, of which 47 deaths occurred. And most of these cases comes from 4 states. So it is estimated that about 165.4 million population are at a risk in these 4 states. So what are the states which have got the maximum number of these leishmania cases? So Jharkhand contributes to that one. A part of the Uttar Pradesh, some of the districts of the Uttar Pradesh contribute to that one. A major part of West Bengal contribute, and it is majorly and severely found in the Bihar state. So we can see that these are the 4 states which majorly contributes to the leishmaniasis cases within the Indian subcontinent. Now, what is the vector which transfers this leishmaniasis parasites from one person to the other person? And the vector is called as the Phlebotomous sandfly. Phlebotomous sandfly is the vector. So we can see a picture of this Phlebotomous sandfly which is shown over here. It has got a short mouth parts, it is a pool feeder, and as you can see, it is a vector of leishmaniasis and several other viral fever diseases. So this is the it is the one which transfers this parasite from one host to the other host. It is most active at the twilight, night, and it's present in the shades also. Now, what are the different morphological form of these parasites which are present within our body? So it is divided into 2 major morphological form. One is called as the promastigote, the other one is called as the amastigote. So if we see the structure of the promastigote, it is a long cylindrical structure with a tapered tail end. Inside it there is a single large nucleus, then there is a kinetoplast, there is a basal body through which the flagellum or the exonym are arising, and there is an exonym, and subsequently a flagellum is there. So this flagellum helps this particular morphological form for its locomotion. Now subsequently, if we see the amastigote stage over here, we can see it's a circular stage which contains a nucleus, there is a kinetoplast which is present, there is a basal body and axonym, but this stage doesn't have the flagellum. So it is immobile, it cannot move through the blood circulation, and it is present within those affected cells only. Now, if we see the stained slide of these Leishmania species, we see over here the left hand side picture, which is the Leishmania promastigote. We can see that the body is stained, there is a nucleus which is at the center, and the long flagella is present. While in the case of the Leishmania amastigote, we can see that this is present, generally infects the macrophages. So from the macrophages it has bursted out. So the small stages we can see which have bursted out from the macrophages stage slides made from a bone marrow which has been affected with the leishmania. So we can easily distinguish with the help of stain both these stages, which is the promastigote and amastigote. Now let's come into the life cycle of leishmania parasite. So what happens is, as I told you, the vector in the case of leishmania is the sandfly. So as soon as the sandfly injects the blood into the human host, it transfers the promastigote stage into through the skin into the human host. So these promastigote stages are nothing but those stages which contains a flagella, so they have got the capability of mobile phases. So these promastigotes are then phagocytized by macrophages or other types of mononuclear phagocytic cells which have got the characteristic property of endocytosis or phagocytosis. So they engulf these promastigote stages and they take them inside their cellular system. Now these promastigote, they transform themselves into amastigote within these macrophages cells. Now within these macrophages cell, these amastigote which has got transformed from the promastigote start dividing or multiplying within those particular cells or the tissue types, producing a large number of their copies. So these macrophages now contains a large number of these amastigote cell forms. So now these amastigote cell forms, as soon as they are formed in a huge number, they burst out from these cells and they start affecting the other macrophages or fresh macrophages, or the next phase is they can be taken up by the bite of the sandfly in the form of a blood. So as soon as the sandfly takes up the blood meal from this patient who is suffering from this leishmaniasis, it ingests the blood. So along with the blood, the macrophages infected cells also comes up which contains the amastigotes within them. So now this parasite along with the macrophages get transferred into the mosquito, into the sandfly. Now in the sandfly, this bursts out to release the amastigote which subsequently get transformed into promastigote in the gut of the sandflies. Now in the gut of the sandflies, the further development takes place and they divide in the gut number of times and finally they migrate into the proboscis of the sandfly so that they can be transferred into the next host system. So if we see over here, the first part of the cycle is completed in the humans and the second part is completed in the sandfly. So the human and the sandfly is playing a major role in the development and the replication and transfer of these stages. And if we see this whole life cycle, we can see that there are only two main morphological stages. One is called as the promastigote, the other one is called as the amastigotes. So this is how exactly the transfer and everything takes place. Now if we see the diagram over here, we can see the main developmental forms of the leishmania promastigotes which takes place within the sandfly's midgut during the infection. So we see that as soon as the sandfly takes up the blood, it takes up these mastigotes and further development takes place. So there is a thoracic midgut, there is an abdominal midgut and there is a hindgut within these sandflies, and most of these development takes place in the thoracic and the abdominal midgut where the development and division and the replication of these mastigotes takes place. So the gut of these sandflies plays a very important role in the development of these things, and if we can see the picture over here by the various color code systems, it shows that how much is the time span in which it develops into the matured form which go into the proboscis and finally it can be transferred into the human beings as a form of infection. Now what are the detection methods or the diagnosis system for this leishmaniasis? So the most standard and the golden standard method for the detection of leishmaniasis or the leishmania parasite within our body is the detection with the help of the microscopic slide. So what happens is, the patient who comes and reports that he or she might be suffering from the leishmaniasis, the patient's tissue section is taken up. So suppose he or she is suffering from cutaneous leishmaniasis, then a part of the skin source are taken. If the person is suffering from visceral leishmaniasis, which majorly affects the bone marrow, the samples from the bone marrow is taken up and the microscopic slides are prepared. After the preparation of the microscopic slide, they are stained with the help of various nuclear stainings shown over here. So if we can see the picture over here, this is a light microscopy examination of a stained bone marrow specimen from a patient who is supposed to suffering from visceral leishmaniasis, and the stage which shows over here is a macrophage. So the cell is a macrophage, and the red arrow shows a amastigote leishmania stage which is present within this bone marrow macrophages cells, and the black arrow shows the kinetoplast of these amastigotes. So we can easily identify the presence of these amastigotes within the bone marrow macrophages, and we can confirm that the patient is suffering from the leishmaniasis disease condition. So this staining method or the slide preparation method is one of the most authenticated and confirmatory method for these things. The other method are the blood tests, which detects the antibody which have been elicited against these parasite, and it is generally a helpful case in the case of the visceral leishmaniasis, because in the case of visceral leishmaniasis it generally circulates within our body circulatory system, so they can be easily detected, and the antibodies which are specific against these parasite which are circulating can be detected from the blood circulation to confirm whether the patient is suffering from leishmaniasis or not. So there are different kits which are available. So I have shown over here one of the kit which is called as the Leishmania Oligo-C test kit. So this is a kit which is based on the DNA amplification and subsequently checking the things on the oligochromatography plate. So the DNA amplification is done, and subsequently with the help of the probe, which are very specific to the genes of these leishmania, they go and bind to this DNA if it is present within the sample, and it imparts a coloration over there. So this coloration can be easily detected, and we can confirm whether the patient sample which has been taken is positive with the leishmania parasites or not. So if we see the picture over here, this shows a diagrammatic representation of this particular test. So the patient sample is taken up, the extraction is done, and finally the amplification or polymerase chain reaction is done, so that a number of DNA copy of that particular patient is done. So a specific region which is found in this leishmania is taken up so that it can be detected, and subsequently the hybridization and detection methods are followed, and under this hybridization method the probe which are very specific to the DNA present in the leishmania are used. So these probes, as soon as they go and bind to the leishmania disease DNA, and they impart a color, and these coloration can be checked on a chromatographic plate. So if we see over here, there is a control slide and there is a test slide. So in the test slide we can see there are two red bands which are shown, which shows that it is positive because the probe has got attached to DNA which have been taken up from the sample, which shows that there is a presence of DNA of the leishmania. So the leishmania DNA is present, due to which the probe has got attached, and it is showing a positive result. So this is how the Oligo-C test is used to check whether the patient is suffering from leishmania or not. Now, what are the various prevention and the control measures which are generally used to control and prevent this particular diseases? Apart from this, there are a number of drugs which are available, but many a times prevention or the control measures are best ways to control the disease condition. So if we see that the travelers are generally recommended to protect themselves from the sandfly bites by wearing the full sleeve uniforms, which doesn't allow the sandfly to bite them during the daytime. And to decrease the risk of being bitten, there are a number of preventive measures which have been issued in the public interest. One of them is to avoid outdoor activities, especially during the dusk to dawn time, because it has been found that the sandflies are generally most active during this time. Now, the other prevention and control measures have been classified into two major parts. One is when the person is within the indoors and when the person is outdoors. So, once the person is outdoors, to minimize the expose of skin, it is generally recommended that the person should wear long sleeve shirts, he or she should wear long sleeve pants, and everything should be properly dressed up. The other part is the person is generally recommended to apply insecticide repellents so that the exposed skin part is not exposed to the bites of these sandflies, and the most efficient repellent over here which is generally recommended is called as DEET, which is diethyl metatoluenamide. Now, when the person is indoors, it is said that the indoors should be well screened, it should be air conditioned area, and it is generally said that the sandflies are much smaller than the mosquitoes. So, it is very essential that the screens which are put on the windows or the doors, it should be minimum sizes so that these sandflies cannot enter through these pores. Now, it is also recommended to spray these insecticide to kill these insects, and generally it is recommended in the areas where there is a endemicity of this particular diseases, the bed nets should be used, and these bed nets have been found to be one of the most important control measures in the rural parts of the world where these insecticide and the drug therapies cannot reach at the proper time. Now, the various drugs which have been recommended and which have been used as the anti-leishmanial medication throughout the world, the first one which is commonly used since 1940s is the pentavalent compound. Under this pentavalent compound, the most important pentavalent compound is sodium satiboglucanate, which is also named as or marketed as Pentostam. So, this is one of the most commonly recommended anti-leishmanial medication. Now, the other anti-leishmanial medication which are specially against the visceral leishmaniasis is called as the liposomal amphotericin B, or which is marketed in the market as Ambizome. Now, this was marketed or approved for the use in the way back 1997. So, it has been used continuously to treat the patients who are suffering from the visceral leishmaniasis. In the year 2014, FDA, which is the Food and Drug Administration, approved the oral agent which is called as the miltefosine for the treatment of cutaneous, mucosal and visceral leishmaniasis, which are particularly caused by Leishmania species. So, there are a number of drugs which are available depending upon the specificity and the severity of this disease. They are recommended by the physician. So, the best way, even though the best way is to prevent by using the bed nets, spray around the areas, make the areas clean so that these sandfly cannot breed on those areas and the vectors are automatically killed. Now, we come into the next part of these diseases, which is the lymphatic filariasis. As the name is suggesting, lymphatic means it is something to do about with the lymphatic system, and filariasis is a nematode worm which plays a major role in causing this particular diseases. So, this disease is caused by 3 species of thread-like nematode worms which are known as filariae. So, these worms are many times referred as the filariae, and these 3 species are Vaucheraria bancrofti, Brugia malai, Brugia timori. So, these are the 3 species which we will be discussing over here. Now, this lymphatic filariasis disease is commonly referred as elephantiasis, because in the elephantiasis, the person who suffers from this lymphatic filariasis, the limbs of this particular patient swells up in a very gigantic way. So, the person is many a times said to suffer from elephantiasis, and this is a very painful and a disfiguring disease which is acquired during the childhood, and the major manifestation or the symptoms occur during the later stage of the life. So, a children gets this disease, but subsequently during the growth time these diseases comes into their lymphatic vessels at the later stage or their lifespan. Now, the lymphatic filariasis, the vector which is involved in this lymphatic filariasis is the mosquitoes. So, the mosquitoes plays a very important role in the transferring of this particular nematode worm from one person to the other person, and the mosquitoes are from the genus Culex, which is this Culex transfer this disease generally in the urban and the semi-urban areas. Then comes the Anopheles and the Aedes. So, all these three mosquitoes are capable of transferring this particular nematode worm from one person to the other person, and many a times this disease is very painful and disfiguring, which we will see subsequently in the lectures. So, 90% of the cases or the infection which occurs throughout the world has been reported from the Vauchereria bancrofti, and while the 10% of the cases are reported from the other two species of this filarial filaria. Now, if we see the picture over here, this is a mosquito which has been shown over here. So, the parasites of Vaucheria are generally causing the 90% of these infections. Now, if we come into the vectors of these lymphatic filariasis, the range of mosquitoes can transmit the diseases as we just discussed, depending upon the geographic area. So, in the African part, the most common vector is the Anopheles, while in the Americas also the most common one is the Culex, while in the Pacific and the Asian region it is Aedes. So, we will see each of these vectors one by one. So, the first vector which we discuss is the Anopheles, which is the most common vector in the African region. So, if we see the Anopheles, by its sitting posture, it generally sits at an angle of 45 or a perpendicular angle, and the palpus is as long as the proboscis. So, the piercing type of mouth parts contains the palpus and the proboscis, which are long, equally long. While in the case of the Culex, which is one of the common vectors found in the American region, we can see that there is a blunt abdomen which is present, and secondly the palpus is short, while there is presence of wing scales which are found in the Culex. While in the case of Aedes, which can transmit the infection in the Pacific and the Asian region, there is a characteristic presence of white stripes within its legs. So, we can easily make out that this is a Anopheles mosquito. So, the Anopheles mosquito has got these stripes, it has got a short palpus, there are pale bands which are present at the basal point of the abdomen, and the abdomen is pointed, while in the case of the Culex, the abdomen was blunt. Now, if we see the picture over here, we can see the filarial worm over here, or the exact parasite which causes this particular diseases. So, we can see the microfilaria of the Vauchereria bancrofti and the microfilary of Brugia mallei. So, as I told you, there are three different filarial species which causes the lymphatic filariasis in the humans, and the most common one is the Vauchereria bancrofti, while the other two species are Brugia mallei and Brugia timori, which are found in the Asian region. Now, this is a picture showing the Vauchereria bancrofti microfilary. Microfilary are nothing but the immature larval stages are referred as the microfilary, while the nematode worm is many a times referred as filary. So, we can see that the microfilary over here, and if we can see that there is a long tail region which is present. Along the body, there is presence of numerous nucleus within that thing, and if we see the microscopic view, we can easily trace out the presence of the Vauchereria bancrofti microfilary within the stain slide. Now, if we see the morphological structure of this microfilary, we can see that there is a long structure which is present. The nuclei are well separated and numerous present within them. So, there is number of nuclei which are present within their body, and the body of the microfilariae has sweeping curves which are present. So, there are sweeping curves which are present. The tail tapers at a point where there is no nuclei present, while the head space is also long and wide. So, if we see this slide over here, we can easily make out the tail region there are no nuclei which are present, while the head region it is long and wide. So, this is the image of the Vauchereria bancrofti microfilariae. Now, let us come into the life cycle of this Vauchereria. So, in the Vauchereria, as I told you, it gets transferred by the mosquito bite. So, the mosquito can be Culex, Anopheles or Aedes depending upon the geographical distribution. As soon as the mosquito transfers the blood into the humans, the mosquito blood contains the third stage of the larva, which are many a times referred as L3. So, these L3 larva enters the skin and goes into the blood circulation of the person who has been infected. So, the adult stages moves into the lymphatic system of the human beings. Now, these adult stages, what they do is they develop and produce a number of immature larval stages which are called as microfilariae. Now, these microfilariae then subsequently migrate into the lymphatic system and the blood channel. So, they move throughout the lymphatic system and the blood channel machinery. Now, due to this movement and a presence within this lymphatic system, what happens that the lymph nodes or the lymphatic system is unable to function properly. In response, what happens that there is an accumulation of the fluids within these particular system, resulting in swelling of the limbs or the arms. So, that is why the patient who suffers from this particular microfilariae or this particular parasite is said to develop the swellings within the limbs and the arms, and many a times it is referred as the elephantiasis, because these arms and limbs looks like the arms and the limbs of the elephant. So, they become so huge that the person is or the patient is unable to move, and the patient generally becomes bedridden. Now, what happens is the next phase of the cycle goes into the mosquito. So, as soon as the mosquito transfers the stages into the human beings, this stages moves into the lymphatic, where the adult gives rise to the immature larval stages, which are called as the microfilariae, which moves into the lymphatic system and subsequently through the blood circulation. Now, these blood are then taken up by the mosquitoes as it shows a nocturnal periodicity. So, what happens is it are taken by these mosquitoes, and the mosquito takes the blood. So, along with the blood, these microfilariae also comes up, and now this next stage of the development takes place within the mosquito muscles and the mosquito midgut. Now, these microfilariae then penetrate into the mosquito's midgut and migrate into the thoracic muscles. Now, where the development start taking place, and the first form of the larva develops, which is called as L1, subsequently the L3 is formed, and as soon as these larval forms are formed, they migrate into the head or the mosquito proboscis, and finally these mosquito, as they go and infect another person, these microfilariae are transferred into that person individual, where the adults then goes into the lymphatic system and the human stages again starts within that particular host. So, the two hosts in this case are the humans and the mosquitoes. In the case of Leishmaniasis, over here the example is Vauchereria. Now, the transmission of the lymphatic filariasis is, as I told you, is generally through the immature larval stages, which are generally referred as the microfilariae. So, they circulate within the blood, peripheral blood, with a marked nocturnal periodicity. So, what happens that during the night time they come on the top of the blood circulation, so that they can be easily taken up by the mosquitoes from the blood circulation. These worms which are infected into the human host generally lives and produces microfilariae for 5 to 8 years. So, just imagine the person who have been affected with the adult form of this filariasis develops gets this these worms which can live within the blood circulation for 5 to 8 years and producing a large number of these microfilariae which are millions in number. Now, if we see the picture over here, it is shown of a person or a patient who is suffering from superior conjunctival this thing, and we can easily see that there is Wuchereria bancrofti worm present within the eye region. So we can easily make out the worm which has moved to the eye region and it is present over there. Now, the other species, which is the Brugia malei, if we take up this species cycle, it is similar like the Wuchereria bancrofti. The L3 larval stages enters into the host by the mosquito bite. So the mosquito transfer along with its blood. So as soon as it moves into the human host, the adult goes into the lymphatic system. The adult produces a number of microfilariae which reaches the bloodstreams. Within the bloodstream, the mosquito again takes up this blood and ingest this microfilariae. These microfilariae then penetrates into the mosquito's midgut and migrate into the thoracic muscles, where the L1 or the first larval stages develop, subsequently the L3 larval stages develop, and finally the migration into the mosquito's proboscis and head region takes place. And now this mosquito has got the developed form of these lymphatic worms, which it goes and transferred into another human host, and likewise this cycle takes place. Now, if we see the morphology of Brugia malei, we can see that the head space is twice as long and as it is broad. So, and the tail region is tapered, and around 2 nuclei appear at the tail region, while the nuclei in the body which is present appears very crowded. While in the case of Wuchereria bancrofti, the nuclei were present and evenly distributed within the body region, and at the tail region there was absence of any nucleus present. So if we see the picture over here, we can easily see the Brugia malei which is found over here, where this stained nucleus are stained, and we can see there is a tapered tail region and a long head region which is present in this particular parasite. So these are the 3 different species which are commonly found in the case of lymphatic filariasis. Now, if we go to the site of Government of India, there is a nasal vector-borne diseases control program which Government of India under the Ministry of Family Welfare and Health is maintained. So in its website we can find all the details of these vector-borne diseases, what are the various types, what are the prevention measures, what are the drugs, what are the drug resistance which has occurred. So under this, if we see the lymphatic filariasis, it says that filariasis is another major public health problem in India, which is only next to malaria. So we can just imagine filariasis is such a big problem in the country like India. Now, the disease in India was first recorded as early as 6th century BC by the famous Indian physician Sushruta, and it has been mentioned in the Sushruta Samhita. And in 1709, a scientist called as Clark called the elephantoid legs in Cochin as Malabar legs. So many a times this elephantiasis is referred as the Malabar legs, and the discovery of filariae worms in the peripheral blood was first made by Lewis in 1872 in Calcutta laboratory. So we can just imagine many of these research have been done in Indian subcontinent. So now let's come in to see these pictures, why exactly it is called as the elephantiasis. As I told you, the lymphatic filariasis is many a times referred as the elephantiasis because it is a disfiguring and disabling disease which is generally acquired during the childhood, but the symptom starts coming up later part of our lifespan. So if we see the legs of the patient, we can see these swelled up legs because these microfilariae worms have gone into the lymphatic system of these patients, due to which the lymphatic system have stopped functioning properly, and there is an accumulation of fluids within these lymphatic system, resulting in swelling and various bacterial infection, which are very prevalent and commonly found in the patients who suffer from this particular diseases. Now, the lymphatic filariasis, if we see, is a disfiguring and disability diseases, and many a times it is called as the lymphoedema, because the lymphatic system, it develops the swelling because of the accumulation of the fluids within this, and the lymphatic system is unable to function properly, and there is accumulation of the fluid, and subsequently as the lymphatic system is unable to function, the lymphatic cells decreases in their number and the patients become immunocompromised, and there is a probability that the patient will suffer from number of these opportunistic diseases such as the bacterial infection. So, over here if we see, the patient is showing a lymphedema in which the lymphatic systems have stopped functioning properly due to accumulation of the parasites within them. Now, in the men, the person who is suffering from this filariasis can develop the hydrocele or swelling of the scrotum, and this is mainly due to infection with one of the parasite that causes the lymphatic filariasis, especially Vauchereria bancrofti. So, we can see that the patient over here, the hydrocele has occurred, which is nothing but the swelling of the scrotum. So, just imagine how painful this disease becomes just because of the development and accumulation of these parasites within our body circulation. Now, it has been estimated that about 120 million people across the tropical and subtropical areas are affected by the lymphatic filariasis, and almost 25 million people have genital diseases, which most commonly referred as hydrocele, and 15 million, mostly women, have lymphedema or elephantiasis of the leg, and approximately 66% of these risk of infection live in the Southeast Asian regions and 33 are in the African region. So, the Southeast Asian regions contribute to 66% of these cases, while the African region contribute to 33% of these cases. Now, if we see the global distribution of the lymphatic filariasis, we can see that they are majorly distributed in the Asian region. If we see the lower central and the southern part of the India is affected with this lymphatic filariasis, while the South Asia is also affected. Some of the parts of the Africa are affected, and America, only 4 countries are currently known to be endemic with lymphatic filariasis, which include Haiti, Dominican Republic, Guyana and Brazil. So, we can see that the red parts indicates the global distribution of lymphatic filariasis, where this disease is very prevalent. Now, if we see the geographic distribution of the 3 species of which causes the infection of lymphatic filariasis, we can see that Vauchereria bancrofti is found throughout the most of the part of the Asia, Southeast Asia, African region, some parts of the America, while the B. malai and B. timori are very rarely found in some of the parts of India and some of the parts of the Southeast Asia. So, the most common and the prevalent one are the Vauchereria bancrofti, which causes 90% of the cases. Now, if we see the website of the vector-borne diseases control program of Government of India, it says that most of the cases of filariasis in India are reported from the states of Andhra Pradesh, Assam, Bihar, Chhattisgarh, Goa, Jharkhand, Karnataka, Gujarat, Kerala, Madhya Pradesh, Maharashtra, Odisha, Tamil Nadu, Uttar Pradesh, West Bengal, Pondicherry, Andaman Nicobar, Daman Diu, and Dadar and Nagar Haveli and Lakshadweep. So, these are the states which majorly contributes to the maximum number of cases, while there are states which doesn't have any freely or indigenously acquired filarial infections which have been reported from these particular areas. Now, if we see the overall infection cases which are reported from the Indian subcontinent, we can see that the red regions are shown as the regions where these filariasis are found, and while the green are the one where they are not found, and 99.4% of these infection in India are caused by the species which is Vauchereria bancrofti, while 0.6% are caused by Brugia mallee, which is responsible for this particular problem. Now, what are the diagnosis or detecting method for this particular disease or detecting the parasites within the blood circulation? Again, the most important method of detection is the microscopic examination. So, as we know that these microfilariae within our blood circulation shows a nocturnal periodicity, which means that the lymphatic filariasis microfilariae circulate within the blood at the night only. So, the blood collection should be done at the night so as to coincide with the appearance of the microfilariae, and the thick smears are made. Subsequently, they are stained with the Giemsa slide and or hematoxylin or eosin slide, and they can be watched under the microscope, while the other blood tests are available in which the antibodies are routinely checked and detected whether the patient has developed the antibodies or developed the antibodies against these particular worms. So, if we see the overall distribution or the status of preventive chemotherapy for filariasis within worldwide in the 2010, most of the countries within the world where these lymphatic filariasis is an endemic problem has started with the chemotherapies or the drug treatments very successfully to just get rid or eradicate this lethal lymphatic filariasis disease condition. Now, the World Health Organization categorizes this particular diseases under the neglected tropical diseases conditions, and it has been reported that in 2007 alone around 546 million people were treated worldwide with the lymphatic filariasis, which many times is referred as elephantiasis. A total number of 81 countries are endemic for the diseases, and it has been treated that there is an increase rate in 48 countries, in which 27 of which are implementing disability prevention activities. So, the treatments have started in most of these 81 endemic countries to just restore and give the persons who are suffering from these diseases the proper treatment, so that these lymphatic filariasis worms can be killed and detected at the very early stages. So, these are the drugs which are generally referred to the patients who suffer from this particular diseases. It is a combination of drugs which is given to the patient, which includes ivermectin and albendazole, and while the other combination type is the DEC and the albendazole. So, most of the drugs nowadays given to these disease conditions are the combination drugs, because if one drug fails or develops a resistance to it, the other drug will definitely kill the parasite or the infecting agent. Now, what are the different prevention methods for preventing the disabilities or increase the disabilities due to lymphatic filariasis? So, the WHO have started with a community home based prevention of disability program, which is done due to the infection of the lymphatic filariasis. So, under this treatment method, it generally recommends that the person should wash the affected limbs where the lymphatic filariasis has occurred, because as I told you that in the lymphatic filariasis, the worms or the microfilariae goes into the lymphatic vessels, it accumulates or causes the swelling of the legs, because there is an accumulation of fluids which occur within this patient, and as a result the limbs and the arms get swelled up, and subsequently the patient is unable to move from his position because the swelling of these things causes him a discomfort. And subsequently the other methods which are generally recommended is the part of the body which have been affected by the lymphatic filariasis should be elevated, so that the pain does not occur and the swelling gets reduced in the case of lymphatic filariasis, like the figure which is shown over here. If you see the figure, the patient who is suffering from the lymphatic filariasis is shown to have his legs in which the lymphatic filariasis is there, the leg is being put at an elevated level during the sleeping posture so that the person's limbs doesn't get swelled up anymore and the person doesn't come into a pain condition. So with this part, I end my lecture over here on this vector-borne diseases, in which I covered the two important vector-borne diseases. The first one was the leishmaniasis and the second one was the lymphatic filariasis, which have engulfed throughout the world and have become a very major problem or medical problem throughout the world, and necessary treatments, if and when detected, should be given to the patient to eliminate the parasites from its blood circulation. And as we saw that in both of these disease conditions, these parasites circulate within the blood circulation, so most of the organs get affected, and due to which the person many a time suffers from organ failures and the other symptoms condition. So with this note, I end my lecture over here. Thank you very much.
Thank you, sir. Thank you once again for giving precious input to this lecture. And dear friends, as we always say that if you want to give your feedback regarding this particular lecture, or if you want to have some particular session on a particular topic, then you can mail us at info.cc@nic.in. We would love to solve your questions also. If you have any queries, then also you can mail us. The next time when Dr. Bhattacharya visits our studio, we would love to take your issues, your problems. Till then, thank you, sir. Thank you so very much.
Thank you.